Good day, ladies and gentlemen. Thanks for the introduction. In the next couple of minutes, I'm going to talk about the integration of the Oraya Therapy as a second-line therapy and share our experience in Germany with you. These are my disclosures. I'd like to start with a rather obvious question: why do we offer the Oraya Therapy? Well, we all know there's a huge number of patients suffering of neovascular AMD, and each year there's a huge number added to that number. So far, only anti-VEGF has shown that it's able to significantly improve the visual outcome. It has a rapid effect, but is limited in time, so we need lots of injections over a lifetime. However, our clinical experience shows us that this doesn't happen. We lose a lot of patients for different reasons. Patients get tired of the injections, patients can't make the appointments because of comorbidity or stuff like this, and we have the risk or actually the fact of undertreatment. This is shown in this figure here. During the first year where the treatment was adequately, we see a nice rise and gain of visual acuity. In the second year, for the reason of undertreatment, almost all the gain is lost and the patient has a poor visual outcome. That brings me back to the question, why do we offer the therapy? The patients demand an alternative to anti-VEGF. We need to maximize the visual outcome, minimize the risk of long-term scarring. There's also the socio-economic point of view. We need to reduce the financial burden of repeated injections. So far, the Intrepid study has shown us a safety profile which is acceptable. And last but not least, there's no other alternative yet. The next question is, to whom are we going to offer the therapy? If we talk about the Oraya Therapy as a targeted therapy, there might be a target population. And this population is described as the PEST responders as defined by the Intrepid study. There are three characteristics which we have to look for to determine whether a patient will benefit from the therapy or not. It's the fluid within the retina or under the retina, it's the lesion size, and the amount of fibrosis. If we look down here, where's the statistical analysis, we see that if we look at lots of fluid, if we got a small lesion size, less than 4 millimeters, and no significant fibrosis, we will have the best outcome. This is a selection process. Nevertheless, if we do select the patients for this criteria, we still have like 60% of the AMD patients included, which was shown in this slide from the previous AMD studies. What kind of diagnostics do we have to perform to select patients and monitor patients? This is mainly the visual acuity. It's the OCT at the beginning and during the monitoring, at the start the angiogram, and at the start as well the axial length measurement to exclude high myopic or high hyperopic patients. Now I want to share with you our results in Germany. Right now in Germany there are 4 to 5 sites who are actually using the device. We mainly use the same inclusion criteria as determined by the Intrepid study. Nevertheless, we have one minor change. Instead of minimum of 3 injections, we demanded a minimum of 6 injections within the last 12 months for our patients. We had a PRN re-injection scheme, and as you see here, in 2014 we had 8 patients treated, of which 6 had a tidy follow-up, and this year we had 45 patients treated, of which 37 got a tidy follow-up. These are the 12 months results of our 6 patients treated last year. As you see here, we have the lesion size. It's all less than 4 millimeters. We have a common age distribution of the common AMD patient, and this is the highest visual acuity the patient had before during anti-VEGF treatment, and the visual acuity at 12 months. So you see there's no significant difference between the visual outcome. It reaches a really good level. But this is the most interesting part here. We have a significant reduction in injections. It's demonstrated in this figure as well. We have almost a 75% reduction, which is highly significant for these 6 patients. And if we incorporate that data into the costs analysis from a socioeconomic point of view, you see that we actually have a significant reduction of total costs for these 6 patients within the 12 months after treatment compared to the 12 months before treatment. So now I want to show you some examples of patients we treated last year. This is a patient who had an average of 5 injections before. And after the treatment, no injection at all. This demonstrates the visual acuity. You see here the red square here shows the highest visual acuity he had since the diagnosis of AMD. So you see after 12 months he reached actually the highest visual outcome he had before and had a dry macular status. This is another patient who responded very well to the treatment, 7 injections in average before to 0 injections. And another patient who had a mediocre response from 7 injections, but still at least a response with a reduction of injections to 4 injections. So this is now the last data slide I'm going to show you. And what I want to point out on this slide is, first of all, this figure here up left. We talked it a couple of minutes ago. We were talking about when does the response affect the patients. We talk about a time frame from 4 to 6 months. The Intrepid study has shown us that if we compare the treatment arm of 16 gray compared to the non-treated patients, we see that between months 0 and months 4, there is no significant difference between the patients. Yeah, they almost get the same injections. But at month 4, it started to become more obvious. The effect becomes more significant, and that actually this is what you can see here. There's a trend. A positive trend illustrated here in the reduction of injection, but it's not significant yet. So we're looking for the next 6 months to become to show that the data is becoming more obvious. We have a reduction of the central retinal thickness. We have a slight improvement of the visual acuity, but these 2 points are mainly due to the anti-VEGF treatment. And another thing which we looked at is the nerve fiber layer thickness. Everybody is saying that it doesn't affect the optic disc, it doesn't affect the retinal ganglion layers. So we also looked at the nerve fiber layer thickness and wanted to see whether it is safe from a nerve fiber layer thickness point of view. And this is the data we got for 6 months. There's no significant decrease in the nerve fiber layer thickness. So so far we have nothing to imply that it might not be safe. So in conclusion, the real-life results are very encouraging if the criteria for best responders are respected. It's important to inform the patient thoroughly with regard to risks and benefits of the therapy, and we need to set realistic expectations. Thank you for your attention.